Today I'm reviewing PROACTIF, a large prospective real-world study of Y90 glass microspheres, or TheraSphere, for hepatocellular carcinoma. The headline is its scale: 989 patients treated across 34 French centers between 2019 and 2024. This is particularly relevant because most prior high-quality Y90 data comes from selected small trial patient populations. Here, 90% of treatments use personalized dosimetry, so the study asks an important practical question. When personalized dosimetry is implemented broadly, what outcomes can we achieve in routine HCC practice? By way of background, Y90 is an established local regional therapy option for HCC, but its place within the treatment algorithms remains heterogeneous, especially in patients with portal vein tumor vascular thrombosis or more advanced disease. The strongest technical evidence for personalized dosimetry came from the dosimetry 01 trial, where a higher tumor absorbed dose improved response and survival in selected patients with locally advanced HCC. However, randomized trials do not fully answer how reproducible that benefit is across diverse centers and across a wider spectrum of disease. PROACTIF was designed to fill that gap. It is a national prospective registry of unselected patients receiving glass microspheres in normal clinical practice. This was a prospective, open-label, non-interventional phase 4 trial across 34 French centers. The primary endpoints were overall survival and quality of life, with response, safety, surgical conversion, and prognostic factors as secondary outcomes. Importantly, this was an older and clinically heterogeneous population. Median age was 71 years old, with 58% of patients having BCLC disease, and about one-third of those patients had tumor portal vein thrombosis. Most patients had preserved liver function with about 82% Child-Pugh-A, but the cohort still reflects the patients we routinely discuss at our multidisciplinary tumor boards rather than a narrowly defined and selected trial group. This is important to note. Dosimetry was a major differentiator to the other studies. 89% received personalized dosimetry planning, and 74% received a multi-compartment dosimetry plan. The mean absorbed dose to the index lesion was 435 gray. Slightly more than half were treated selectively. The overall efficacy signal is strong. Median overall survival for the full cohort was 21.8 months, with a 12-month survival of nearly 70%. As expected, survival separated by BCLC stage: 31 months for BCLC-A, 27 months for BCLC-B, 21.1 months in BCLC-C, and 8.4 months in BCLC-D. The key point is not that these stages are equivalent, they are not, but that a predominantly BCLC-C cohort still had a median overall survival exceeding 21 months. This is comparable to systemic therapy trials. Best objective response rates by mRECIST combining complete and partial responses was 67.7%. Quality of life is also worth highlighting. Median time to deterioration on the FACT-HEP was about 11 months. This gives us a patient-centered complement to survival and response, though it should be noted that the completion of the quality of life assessment was not very complete. This is a hard to ensure metric, and many trials struggle with this. This slide contains the most clinically compelling data. First is the dose survival association. Median survival increased from 16.8 months when the index lesion absorbed dose was less than 200 gray to 30.7 months when it was at least 400 gray. Because this is an observational registry, dose is not randomly assigned. Patients who can receive higher absorbed doses may differ in anatomy, tumor distribution, and liver reserve. Even so, the magnitude and direction of the association are highly consistent with the dosimetry 01 trial and reinforce the importance of pursuing a lesion dose of at least 400 gray when it is safely achievable. Second, low-extent portal vein tumor thrombosis did not carry the same prognosis as more advanced PVT. Patients with VP1 or VP2 disease, which means limited vascular involvement, had a median overall survival of about 25 months, which is very comparable to the 23 months in those who were seen without PVT. Outcomes did decline as soon as you had more advanced vascular thrombosis. In the VP3 and VP4 arms, the survival was 14.3 and 10.1 months. This may suggest a role for combination strategies in these more advanced patients. Finally, 11% of patients ultimately went on to curative intent surgery. That does not prove that Y90 caused the conversion, but it emphasizes why response should be used to trigger renewed surgical and transplant discussion. In discussion, I think PROACTIF is best viewed as a practice-reinforcing rather than practice-changing study. Its main contribution is the external validation of multiple prior randomized trials. It demonstrates that the favorable dose-response signal seen in other smaller prospective trials can be reproduced across many different centers using glass microspheres and personalized dosimetry. The benefit appears especially relevant for larger lesions, where achieving an adequate dose to the tumor can be technically difficult. The PVT finding is also clinically useful. VP1 and VP2 tumor thrombosis should not automatically exclude a patient from Y90. We should consider the anatomic extent of the thrombosis, the liver function, tumor distribution, and an ability to deliver a selective dosimetry-guided treatment. However, we should still remain more circumscript with patients with VP3 and especially those with VP4 disease. Although cross-registry comparisons are very difficult to do, and this should remain hypothesis generating. PROACTIF appears to have more favorable stage-specific survival than the resin and CERT registries, but those were different patient populations with different microsphere platforms, treatment eras, reporting practices, and dosimetry approaches. It would be inappropriate to attribute these differences solely to glass microspheres or personalized dosimetry. Finally, safety ascertainment was limited primarily to serious adverse events, and this study was industry funded, both of which should guide our interpretation. So how should this influence practice? First, personalized dosimetry should be the default whenever feasible. A 400 grade tumor absorbed dose goal is a useful technical benchmark, but always must be balanced against the normal liver dose, functional reserve, and target volume. It is not a universal mandate at the expense of safety. Second, low extent PVT, particularly VP1 and VP2, should prompt careful consideration rather than reflex exclusion. Third, selective treatment is desirable when anatomy permits, because it preserves the uninvolved liver and facilitates higher doses to the delivered segment. The selectivity versus non-selectivity survival comparison is associative and not causal, but the clinical rationality is sound. Finally, treatment should not be viewed as the endpoint. It is at the first post-treatment restaging, every responder should return to the multidisciplinary review to assess for more curative intent therapies such as transplantation or resection, or if additional local, regional, or systemic therapies are needed. The 11% of surgical conversion rate is a reminder that Y90 can serve not only as a definitive local therapy, but as a bridge or downstaging strategy. To summarize, PROACTIF is the largest prospective real-world registry of Y90 glass microspheres in HCC to date. It reports a median survival of 21.8 months overall and a strong association between tumor absorbed dose and survival. Additionally, there are encouraging outcomes for carefully selected patients with VP1 or VP2 portal vein tumor thrombosis. Safety was favorable at the serious adverse event level, and 1 in 10 patients ultimately went on to get curative intent surgery. For me, the central takeaway is not simply that Y90 works in trials. It is a technique that matters. Personalized dosimetry, selective delivery when feasible, thoughtful PVT selection, and repeated multidisciplinary reassessment appear to be the components that inform radioembolization as an effective treatment strategy for HCC. Thank you.